And our project looked at discharge prescription from discharge from hospital and medication reconciliation. Okay, so in terms of the background, as you can see, medication at discharge it can be a major problem, and it can lead to significant adverse drug events and potential harm to patients. Our aim statement originally was to have every patient discharged from the Pascal Hospital ACU have an accurately reconciled discharge prescription that is shared with the patient, their community pharmacists, and community care providers. Our updated aim statement was to look at reducing medication discrepancy at discharge by 50% from 4B and return to the community by September 1st, 2021. So this is a slide of our aim and our driver diagram. So as you can see, our primary drivers, there were 4 main primary drivers, including communication, discharge prescription process, medication tracking, and practitioner time. I'm going to focus mainly on the first primary driver, communication, which led to our secondary drivers and change ideas. So initially there was no standardization or form for discharge prescription. So a standardized medication reconciled discharge prescription was developed and used. There were also transcription errors, and there were also difficulties with illegible handwriting. So printing this form off helped to alleviate some of those problems. There are also issues with the form being filled out correctly. So one change idea was to educate nurses, physicians, pharmacists, and unit clerks on how to fill out the form and who to send the form to. There is sometimes some difficulty between congruence of the discharge prescription and the discharge summary. So a change idea was to help track or to track accuracy of completion of the form at admission and discharge, and then provide feedback to the team. And another change idea was auditing, comparing discharge prescription with the discharge summary. Another secondary driver was looking at a coordination of providers between inpatient and outpatient. So a change idea was to follow up with the pharmacy for feedback from the discharge prescription and to stamp the discharge prescription with the unit contact number. So if the pharmacy had questions, they could call back to that unit. And also giving a patient a copy of the discharge prescription as well. In terms of key learnings and reflections, I felt that my key learnings and reflections related to the aim statement. Initially, we had a very wide aim statement, and we had difficulty narrowing it down to an achievable project. Eventually, we managed to narrow it down to something that we could achieve. We started off with the solution, and rather than looking at the problem, and it took us several adjustments of that aim statement to find a narrow enough statement that we could achieve. And that was what I found very memorable. And on to you, Dr. Taylor.
All right. Thank you, Dr. Ellwood. So I'm going to pick up with some of the information that we picked up through our process. And the first thing was auditing the actual discharge form, where we did find that the form is being used 96 to 100% of the time. So that was a success. However, as you can see, the administration of the form was suboptimal, and there was lots of gaps. And there was still at least one discrepancy on at least 70% of the charts that were audited. And so the form itself wasn't the answer by itself. We also did a survey of the receiving end of the discharge prescription, the community pharmacists. And the win was the form helped them better understand and fill the discharge prescription. And they felt like it decreased their work. But at the same time, they were still phoning back to the hospital at a high rate to clarify the discharge prescription. And they also noticed recurrent errors. There was an opportunity to see if we could theme these and do better. And then I think another big win was the degree of engagement in some of the community pharmacists for partnering to keep working on this process. Our next steps, we are in the process of providing better education about the use of the form, not just to the physicians, but to the entire care team on the accountable care unit, so that we are filling the gaps with the administrative errors, and we're going to do a prospective audit and feedback to the group so that they get some information around their performance. We are beginning a process of process mapping for all the contributors to this team-based approach to make sure that we get a decrease in the discrepancies over time, and we'll be tracking that going forward. And then finally, it's apparent to us working on the ACUs, Dr. Bahari-Walla earlier and Dr. Cuddington coming up for the next cohort, that the ideas that we've been working on independently probably merge together, and we'll be looking at creating some synergy between our ideas and our process. Personally, for me, about learnings and reflections, I have sort of three buckets. One is the biggest chunk of learning had to do with knowledge around run and control charts and QI data, and passing this along, although it didn't manifest in this presentation, to the other work we do on ACUs and sharing how to look at our units with nursing leadership, nursing educators, pharmacists, and even our patient family advisors. I think this journey has reinforced the opportunity of accountable care units with the team that's already in place, the structure and process we have to make it truly a continuous improvement environment. And then finally, my most positive reflection is the way things are building up at the Pasco Hospital with Dr. McNee having done the CQIP program, and then Dr. Pepler, and in this cohort, myself with Dr. Ellwood and Dr. Bahari-Walla, Dr. McDonald, and then going forward, Dr. Liskowich and Dr. Cuddington, and how we're all learning to see the system in a similar improvement vein.